A good day to everyone, and welcome to our webcast, Benefits of AHRQ Patient Safety Organizations, Success Stories from Hospital PSO Members. My name is Diane Cousins, and I will be your moderator and host for today's webcast. Before we get started, there are a few standard housekeeping details. First, if your computer freezes during the presentation, use the F5 button on your keyboard to refresh your screen. It might simply be a lag in the advancing of your slides due to your internet connection speed. So you can also try logging out and logging back into the webcast. If you need help at any time during the webcast, you can use that Q&A icon at the bottom of the screen. Let me introduce you to the webcast console. All the components on the console can be resized to fit your entire browser window, or they can be moved or minimized to the menu dock at the bottom of the console. If the slides are too small, click and drag on the lower right-hand corner of the slide window to make it larger. For closed captioning of today's webcast, you can click on the icon for closed captioning, and a new window will display the captioning for you. The last portion of the webcast is reserved for discussion based on questions you've submitted, and you can do this at any time by clicking the Q&A icon at the bottom of your screen. Type your question into the Q&A box and submit, and we welcome your questions and comments. Today's slides are available for download by clicking on the icon at the bottom of your screen that says Download Slides, and this will generate a PDF version of the presentation that you can download and save. We have additional resources available under the Resources icon, such as links to the PSO program website and other information about PSOs. At the conclusion of today's presentations, an evaluation survey will pop up in a new window, so be sure to enable pop-ups during this webcast. To help provide some insight on the benefits of AHRQ Patient Safety Organizations, we are pleased to welcome our speakers. Our first speaker is Vereline Johnson, Patient Safety Officer at St. Francis Medical Center in Cape Girardeau, Missouri. St. Francis Medical Center works with the Center for Patient Safety PSO in Missouri. Our second speaker is Chris Dickinson, Chief Medical Officer at C.S. Mott Children's Hospital at the University of Michigan Medical Center. Mott Children's Hospital works with both the MHA Patient Safety Organization and the Child Health Patient Safety Organization. Again, my name is Diane Cousins. I lead PSO operations as a health scientist administrator here at the Agency for Healthcare Research and Quality, known as AHRQ, and I will be moderating this session. Although today's webcast is focusing on success stories of hospitals working with PSOs, you'll need some background for context, so my presentation will briefly summarize for you key points about patient safety organizations. There are many other areas about privilege and confidentiality protections of the law and other concepts that are important for your deeper understanding of it, such as patient safety work product and patient safety evaluation systems. These would not be conveyed well in the few minutes I have today, so AHRQ is exploring future sessions that will address these areas in a more focused way. First slide, please. The Patient Safety and Quality Improvement Act was signed into law on July 29th of 2005, and the final rule became effective in 2009. The Act authorized the creation of entities called Patient Safety Organizations, or PSOs. It created a voluntary reporting system that supports a culture of safety for all healthcare providers in all healthcare settings. The Act provides privilege and confidentiality protections for information called Patient Safety Work Product, or PSWP, when providers work with PSOs to improve quality, safety, and healthcare outcomes. To enable national information to be aggregated and analyzed for trends, Congress authorized the creation of common formats, which are common definitions and reporting formats. And because Congress envisioned a national learning network for all of healthcare, it established a network of patient safety databases. where PSOs and eventually others can share the information in a non-identifiable way. And information is just beginning to flow to this level. These findings will then be reported annually in AHRQ's National Healthcare Quality and Disparities Reports. Next slide. Now, AHRQ is the agency that implements the law and officially lists PSOs. And so 2 key points about PSOs. Almost any entity can be a PSO or operate a PSO, and there are a few exclusions. Just one example, a hospital cannot be its own PSO, but its health system of which it is a part can operate a component PSO. The role a PSO serves is that of an independent external expert that collects, analyzes, and aggregates patient safety work product in a legally protected environment to develop insights for its providers into the underlying causes of events. So who qualifies as a provider? Well, there's a very specific definition for providers in the rule. Generally, a provider can be an individual, such as a nurse, a physician, or a pharmacist, respiratory therapist, a facility, such as a hospital, a nursing home, or retail pharmacy, or the parent organization of that facility. And what's important is that the confidentiality protections apply not just to the reporting provider, but to any providers named in the PSWP, as well as the facility where the event occurs. Now, these events can be incidents, near misses, or unsafe conditions that adversely affect healthcare quality, patient safety, or healthcare outcomes. Common formats are a key component to fulfilling the national learning system that Congress envisioned, and they provide a uniform way to measure patient safety events clinically and electronically, and permit aggregation and analysis, not just locally, but regionally and nationally as well. Next slide. There are many benefits to working with a PSO, and in fact, a provider can actually work with one or more PSOs of their choosing, as you'll hear today. Because the Patient Safety Act is a federal law, its protections are national in scope. So no matter where the PSO is located, its reporting providers can receive the protections. A PSO focuses on improving quality, safety, and healthcare outcomes. And to remain listed, PSOs must conduct certain patient safety activities and develop and disseminate information such as recommendations, best practices, and protocols. A PSO also provides expertise in areas of importance to the provider, and you'll hear more about this from our speakers. A very important benefit is that a PSO can convene its reporting providers in a protected way to leverage learning, and many are doing this through safe tables. And a PSO can aggregate greater numbers of events than any single provider is able. And this helps providers see issues they might not otherwise see and learn about rare events as soon as possible. Next slide. Many hospital providers are watching an important provision in Section 1311 of the Affordable Care Act for requirements of qualified health plans, or QHPs, and marketplaces. And Section 1311H requires certain hospitals to have a patient safety evaluation system, which, as defined here, means working with a PSO. Now, all of the quality requirements for QHP issuers and marketplaces have been phased in. And similarly, in March of last year, CMS finalized standards to phase in the implementation of this Section 1311H. In the first 2 years, beginning January of 15, the Phase 1 implementation draws on Medicare standards and requires that the issuers ensure that certain contracted hospitals with more than 50 beds are Medicare certified hospitals or are Medicaid-only hospitals and are subject to Medicare hospital conditions of participation standards. So where are we now? Well, CMS is in the process of determining the next phase of implementation for QHP patient safety requirements. So before January 1st of 2017, CMS intends to issue further rulemaking to require issuers to meet patient safety standards including to contract with hospitals that use PSOs if those hospitals have more than 50 beds. Next slide. If you're preparing to work with one or more PSOs, this slide gives you an idea of the number of PSOs serving providers in your state. And in short, 38 of 84 currently listed PSOs are serving providers in every state, and in most cases, more providers are available to you. Next slide. Now you can find information on PSOs on the PSO website. The official publication of all federally listed PSOs is maintained here by AHRQ. And at the PSO website that you see here, providers can search for PSOs by different variables using a selection tool fed by information provided by PSOs, including what region they serve, the PSO's specialty, if any, the type of providers they serve, and the resources they provide. So we invite you to visit the PSO website at pso.arc.gov. And I hope this information's been a helpful overview. So without further delay, let me hand it over to our first speaker, Vereline Johnson. Vereline?
Thank you, Diane. My name is Vereline Johnson, and I'm the Patient Safety Officer at St. Francis Medical Center. St. Francis is a 280-bed regional tertiary care facility located in southeast Missouri, and we serve over 560,000 people throughout a 5-state area. The medical center is a Catholic healthcare provider, which features a Level 3 neonatal intensive care unit and a Level 3 emergency and trauma center. Next slide. Our decision to join a PSO was not very difficult. St. Francis Medical Center formed a relationship with the Center for Patient Safety in Missouri in 2005. And in 2008, our center became the one of the first federally listed PSOs. So because Missouri Health Net regulations at that time required hospitals to contract with a federally listed PSO by January of 2010, we explored the possibility of contracting with the center's PSO. Our decision to join the PSO was also based on the fact that we were already working with them in patient safety activities and in developing our safety culture. Our PSO also serves not only hospitals but medical offices, long-term care facilities, and emergency medical services. Next slide. St. Francis Medical Center utilizes our PSO in a variety of ways. We submit patient safety events and patient safety information and data to facilitate analysis and learning. We participate in many of the PSO education and training sessions that are offered, and we also participate in several of the collaboratives, including Just Culture, and initiatives such as CUSP, Stop BSI, and Stop CLAPSY. These are all aimed at improving patient safety and achieving better outcomes, so we were very happy that those were offered through our center. The PSO also offers expert guidance and assistance in developing our workflow to ensure that we're in compliance with the PSQIO regulations. In addition, we benefit from other services like the legal consultation, PSO alerts that are published periodically, our quarterly PSO newsletter that shares very valuable information and gives feedback in the form of best practice recommendations. So those are excellent services. Next slide. In the beginning, our expectations were limited because the PSQIA was new legislation in 2005. So our focus at that time was just on ensuring that we had a mechanism to submit our data, and then, of course, receiving feedback from the PSO in the form of practice alerts. So when the final regulations were published in 2008 and effective in January of 2009, as Diane mentioned, our goal was also to receive assistance in just creating the infrastructure to establish our internal PSO procedures and policies so that we would receive full protection of our PSWP. Next slide. Our actual experience when working with the Center for Patient Safety PSO has far exceeded our expectations. We have had some excellent experience in working with them. Some of the excellent resources are listed here. When we first began working with the PSO several years ago, they provided a sort of an orientation implementation toolkit for us that included step-by-step instructions on how to establish all of the things that we need to have in place. Then they provided educational offerings that explains in very great detail PSWP, our Patient Safety Evaluation System, and then the confidentiality and privilege protections that were not as clear as maybe they are now after years of kind of going through and looking at those things. We also received assistance in templates for our policies. We didn't have to start from scratch, so the sharing within our PSO has been excellent in getting us those things that we needed. We were able to individualize those to our facility. We do receive quarterly facility dashboards with our facility-specific data and an analysis of that so that we can share that with our employees, our Patient Safety Committee, and all the way up to our board, governing board. We also attend our PSO participant meetings and our PSO annual meeting, and we do participate in safe tables, and those are discussions that allow us to discuss adverse events and vulnerabilities, and then evaluate and analyze that information, identify prevention strategies, and as a group, networking together, provide some best practices and recommendations, and then that information is consolidated and actually passed on to the members of the PSO. So it's a very good networking experience. We also receive PSO alerts and watches, and that's just part of that reporting back to us once the analysis is done to look for trends and things like that. We also receive a PSO annual report, and it lists all of the types of events that have been submitted, along with lessons learned and recommendations as just an overview, a review of those things that have been sent out through the year. And one of the other things that we received is good legal and operational support. If we have a question about legal or protections when it comes down to surveys and things like that, we're able to get that information, and the turnaround time is excellent. Next slide. So I feel that our PSO has fulfilled many of our needs when we look at the legislation and how we want to improve our patient care by including our data in that big pool of information that would help us to look at opportunities for improvement. They provided much needed assistance to us in creating our work processes, the educational opportunities on specific requirements of the legislation that I mentioned. We also received hands-on assistance in setting up our electronic database and our patient safety evaluation system within our facility. The templated policies and forms were very beneficial, and we were able to tweak those and individualize them to our facility. We talked about the legal consultation regarding legal protections and privilege, and also just integration of safety culture and the patient safety improvement activities has been very valuable to us. Next slide. St. Francis Medical Center submits patient safety events and data to the PSO, but we also submit near miss and some unsafe conditions. And when we looked at that and started working with our PSO, we recognized that we needed to improve our reporting of the near misses. And in an effort to encourage our staff, we introduced the Good Catch program in 2010, and this is based on a program created by MD Anderson Cancer Center. The Good Catch program allows the staff members to be recognized by leadership, and they also receive an award certificate that they can post within their department or in their home. And each award recipient they're featured in our monthly newsletter, and it goes throughout our facility, and that is accessed by visitors and patients throughout the medical center. We feel that this program creates a positive atmosphere for submitting potential errors so that we can look at those things that could be an error but just hadn't reached the patient. So it's been excellent. Our first Good Catch Award was presented to a non-clinical staff person. It was a dietary hostess who observed an elderly patient attempting to get out of the bed. He had a yellow armband on, which meant that he was high risk for falling. She alerted the unit staff, and they were able to intervene, and that prevented a potential fall. So we presented that first certificate, and she was very proud of that. Since implementation, we have presented about 218 Good Catch Awards. Next slide. I think the Good Catch program has really proven to be a valuable tool to improve patient safety within our organization. I say it's just another tool in our tool belt to help improve safety. We periodically share our Good Catches with our PSO, which features them in the quarterly newsletter, so we do a lot of sharing of information throughout the facilities. And then in addition, we have several process improvement projects that were completed as a result of our Good Catch program. We had one, and a couple of examples are listed there, where patients had undergone a spinal procedure and had x-rays ordered upon discharge. The 5-view instead of the 3-view films were ordered on some of those patients, and that, of course, that would increase the exposure to the patient. So we had a couple of Good Catch awards presented, and we stopped and looked at that information and found out that that was happening within that department. So a team was brought together to look at the process. They implemented some changes, and we have not had one of those since that particular process. We haven't had one of those reported. Another project involved 2 medications that were used in our pain center, and they had identical labels except for the 1 milligram and the 2 milligram dose. And the physician in the pain center actually reported this as a near miss, and her and the PharmD contacted the manufacturer, and we were able to have the labels changed, and it was a national change that occurred. And so we were really happy that we were able to improve safety not only in our facility but nationwide. Next slide. Next slide. I think the value of a PSO to us is very, just very deep-rooted, because before contracting with the PSO, our focus was on reporting actual events that reached the patient or that caused harm. So the PSO analyzes data and reports trends, and we now report those trends, and we report our near misses to the PSO. And a couple of PSO alerts that we have received, because this is the part that really helps us, is that after the PSO analyzes the data, then they publish a PSO alert. And there was one in particular that included high alert medications. And we recognized, or the center reported, that 1 in 5 medication errors were reported to the PSO in 2014, and these involved high alert medications. So as a result of that, the PSO sent out an alert, and it contained best practice guidelines, and that was issued to all of the participating facilities. Next slide. So looking back on our experience, I would recommend to any facility seeking a contract with a PSO to contract with one that has a history of conducting patient safety work product and improvement work. I think that the process is very seamless, and they would be very dedicated to improving patient safety. The networking is in place so that it will just really improve the amount of information and the work that we can do with our patients. Also, I would ensure that you have complete and accurate data entry when you enter it into the database to ensure accurate data analysis and feedback. I think that's something that we've learned through several years of working with the PSO, and we are actually now looking into electronic submission so that we can have a larger number of our data points submitted. Also, establishing your roles and developing your policies and procedures among your PSO work group within your facility helps to ensure that all of your responsibilities are carried out and that your facility adheres to the requirements of the legislation. So I feel that that's very, very important to have that. Next slide. Although we have had great success in working with our PSO, we do have some evolving needs, and these include assistance with more robust event reporting and analysis at the facility level. We do use the Joint Commission template for event analysis, but we could probably benefit from more robust analysis and feedback. I think collaboration with the PSO's IT staff to assist us in moving toward that electronic event reporting and data reporting is very important. We are working with their IT staff right now to establish that process. And then I think more information on best practices for reducing unnecessary hospital admissions in light of the hospital readmission reduction program, that we hope to get some information that would help us to improve our outcomes in that area also. Next slide. So overall, I think allowing our facilities' event data to be used with other organizations' data, both locally and regionally, to pick up on trends and hot spots that need to be addressed is very important. We are just reaping the benefits of being able to network and have that information sent back to us in the form of those good best practice guidelines and recommendations. And then having a team of knowledgeable staff available to assist with patient safety activities and to promote that culture of safety that we all are working toward, and also that encourages that open reporting on every level is very important. So we share a lot of our recommendations and findings and analysis with our workforce in many, many ways. So we're hoping to continue to improve. Our goal in our facility is to really, and even within the PSO, is to move toward that safe care 24/7, 365, and that's by promoting that culture of safety. And that's all I have for today, and I'll turn it over to Chris.
Hey, thanks, Vereline and Diane. I really appreciate the opportunity for being able to speak today. I would just like to start off by saying I think many of the things Vereline just talked about, the fact that PSOs have helped with transparency and alerts and good catches. We share the same things that in Cape Girardeau, Missouri, here in Ann Arbor, Michigan. So just next slide. So I'm the Chief Medical Officer at the C.S. Mott Children's Hospital, and that's part of the University of Michigan Health System. We're a 220-bed children's hospital located in this building you see here in the picture. We have a nice new building. Also in this building is a 50-bed maternal unit, so we keep the mothers and the kids together, and we are still physically attached to the rest of the adult hospital. Next slide. Our background is that we have shared resources with the University of Michigan Health System, so our risk management, quality improvement. Myself as the Chief Medical Officer in the Children's Hospital of Mott. We also have a Chief Nursing Officer here. We both report to a system-wide CMO and CNO. Within our health system structure, there's a fair amount of flexibility to engage in quality improvement and safety activities that are unique for pediatric care. So one of them I'll talk about later on is medication safety. But we still have to balance that, obviously, with what's going on in the health system as a whole, because our patients can sometimes move back and forth between the buildings. We like to think of the University of Michigan as a leader in QI efforts for adult care, and we thought we should also be one in children's care, but we wondered how we would do this, and the PSOs helped us with this. Next slide. So what was our decision and why did we do it? Again, like Vereline, it was pretty simple for us. We felt strongly that we had a responsibility not only to improve quality and safety in our own hospital, but to help other hospitals improve care for children around the country and especially locally within the state. In our health system, we had a longstanding policy of sharing medical errors with families. We like to think that we will share errors with families even if they don't necessarily know about the area, quickly settle claims, and then share openly the experiences about these mistakes and or harm that we've caused in order to improve care. And for us, then, the PSO was merely an extension of this kind of internal philosophy that we've had in our risk management structure. Next. Why work with two PSOs? Well, we thought we needed to learn from others, both locally within the state, but also nationally with other children's hospitals. So for us, two PSOs seemed to fit best. The first one was the Michigan Hospital Association PSO, which is our local one where we had a pediatric safe table, and then with a larger one with Child Health PSO, which is a national one with children's hospitals. Next. The MHA, or Michigan Hospital Association PSO, was created pediatric specific. We eagerly joined this. We meet in a safe table every quarter. When we went to this, we expected to be the leaders and the best. But what we found is that this wasn't always the case, that the problems and issues we had were not necessarily unique to the University of Michigan or Mott Children's Hospital. Other places had similar issues, and therefore the solutions often came from many different ideas, organizations, and this philosophy of all teach, all learn was critically important for us. When I go off to these safe tables, I literally get my battery recharged each time I go off and come back with probably a lot of great ideas, most of which we can't all implement at once, but I drive our staff nuts. The free sharing information for us is the biggest win. Yes, we get the patient safety alerts. Those are helpful. But the actual conversations that we have, and then the ability to actually meet other colleagues and then be able to pick up the phone and talk to other people has been the biggest win from us. We learn from everyone else. Next slide. The Child Health PSO, well, although our local PSO is helpful, we have some unique needs. We have a specialized 20-bed pediatric cardiothoracic ICU. And so we'd like to be able to talk to people about those specific issues. And so for us to do that, we needed to really work with other large children's hospitals around the country. And for that, the Child Health PSO was good. It's affiliated with the Children's Hospital Association with 51 member hospitals. And this work was in large part spurred by the Solutions for Patient Safety Hospital Engagement Network. And SPS started in Ohio, much to our chagrin here in Michigan, as a CMS transformational grant, and it's been wonderful. Groups of children's hospitals here work on healthcare acquired condition, or HAC reduction, and we've learned a great deal from both SPS and the Children's Hospital PSO. Next slide. How do we use our PSOs? Well, mostly we just listen, and we learn a lot. We learn a lot from others. We learn all sorts of specific questions. I mean, you can sit and listen to a webinar like this today, but you may come away with, how do you really get that CLABSI rate that low? And you're going to get drawn into these things. Did you use a bundle? What was the bundle like? How did you implement that with the staff? How do you retrain your new staff? How do you really change that culture, that safety culture? Did you train everybody together, the doctors and the nurses? Did you do it separately? Did you do it by web? So all of that stuff and being able to bring that robustness together and think about what will work at your institution is really a big win for this. Next slide. Our original expectations were we're going to join the PSO, and of course we're different. Our patients are obviously sicker than everybody else's. Our families will be more difficult. And we're probably really, really struggling in a particular area and really good in another area. Next slide. Well, what we found is that we're really similar to other places. Everybody's got sick patients. Yes, some of our patients are sicker, but most are not. Families are families. Everybody's got a difficult family. In some places we're ahead of the curve where we thought we were really struggling. In other places we go, oh my God, why haven't we done this before? Next slide. How does the PSO fulfill our needs? Well, we have lots of issues to work on. Part of this is how do we prioritize? And so, again, talking to other hospitals is helpful in that. How do you implement change? Again, talking, helpful. How do you break down barriers? How do we fit relative to these other organizations? And the PSO helps with all of these issues. As I said before, reading publications is very helpful, but doesn't necessarily always answer all the questions you have on any one topic. And you can sometimes get that done through a safe table and PSO. Next. So one of them that came up for us was pediatric medication standards. Like many other children's hospitals, we had major issues with medication safety. Dosing is based on weight and can vary 100-fold. We could have a 1-kilogram baby or a 100-kilogram adolescent, and thus most of the doses that we dispense from our pharmacy and administer to our patients are quite patient-specific. And in our hospital, we're at a little over 1.3 million doses dispensed each year. And so if we were really 99.9% accurate, which is you think be really, really good, that would still yield about 3 per day that would be wrong in getting to a patient. So we need to be much better than that to really think of ourselves as a good, high-reliability organization. And we found one particular brand of or group of medications which was a problem for us was compounded oral medications. So these are drugs that do not come as a solution that you could administer to a child in a commercially available preparation. And so there was no real standard concentration. Every pharmacy would mix it up differently. They would grind up the pills and put them into some type of a solution. And we did a statewide survey that showed about over 50% of the medications, we had about 200 listed, and over 50% of them had 3 or more standard concentrations. And one drug that I use as a gastroenterologist, metronidazole, had 9 standard concentrations. Next slide. And obviously, we had a big problem with this. Kids would come into the hospital. The families wouldn't know what concentration they're on. They're just saying they're giving their kid a teaspoon of some medication, and we would screw it up and have either an underdose or an overdose when we tried to follow this. So we thought we needed a statewide standard compounded oral medications list, but how would we do this? So we went out to try and get buy-in from pharmacists, doctors, and hospitals, and our starting point on the hospital side was the Michigan Hospital Association, PSO. Every other hospital had the same problem. We got together, and we proposed this idea. They liked it, and then we were able to bring together subject matter experts to work on what standards we would actually do. Next slide. So we developed standards and then created a website, mipscompounds.org. We got a little logo there you see on the bottom of this slide, and it will include our statewide standard. All the pharmacies in the state have it. All the hospitals in the state are using it. We've taken it to the physician organizations, and we're all using the same standard now. And for us, this has been, we think, a big win, and we'd like to actually do this nationally now. Next slide. So what kind of lessons learned and evolving needs do we have? Well, what we've learned is we need to listen and then even listen some more. We probably need to bring as many disciplines as possible to the table. That would include physicians, nurses, pharmacists, respiratory therapists. And under the PSO rules, as Diane laid out in the beginning of this talk, all of these people can come and be listed as, quote, providers. Report your events so that we can all teach, all learn. We've gotten scoring systems from this on how we would prioritize some of our work. Other questions that we've come up with is how do you get work done when you're just a smaller unit, as we are in this children's hospital within a larger health system? Can you really manage then from the middle, and how would you do that? Next slide. The value of the PSO has been immeasurable for us. They help or build or reinforce our own internal culture where it's safe to talk about real safety concerns. They allow you to learn from others and also share your own expertise. And then for us, being in multiple PSOs has allowed us to do this work at various levels, including state, nationally, and within a specialty area. Next slide. And I guess that's it. So thank you very much, and we're ready for questions. Diane?
Thank you, Chris. Actually, thank you, Vereline and Chris, for excellent presentations. And this concludes our presentation portion of the webcast. So to participate in the question and answer session, you can click on the Q&A icon at the bottom of your console to submit questions. And I see that we have received several, so I think many of you have found that. Additionally, we remind you that you'll be completing an evaluation survey that will pop up in a new window. So please be sure to enable pop-ups to complete that survey because your feedback is really important to us. So, and definitely remember to click submit after you've completed the survey. So let's go into questions and answers. This first one is actually for both Vereline and Chris. Can you give us a sense of how you identified the area that you would focus on in your success stories today?
Yes, this is Vereline. We actually reviewed our risk incident data, and we used the MIDAS system. And we review that every year and periodically throughout the year, and we noticed that most of our events were actually events that reached the patient, and we didn't have as many events that were near misses or unsafe conditions. So we wanted to focus more on the near misses, and so we felt like we could really impact patient safety by preventing those potential harm events and looking at trends that way.
Yeah, this is Chris. I think we had a very similar one. Part of the advantage of PSOs is I wrote down a note here that we ought to have a better good catch program in our hospital, so I'm taking notes from Vereline on this one. But for us, the medication safety one was just we struggled with this and struggled with it. And it was very disappointing when I had to go to leadership and talk about the fact that we had another medication error that harmed a kid, and we did it again, the same medication almost in the same way. And so when we looked at all of our events, a lot of them were adverse drug events. So again, we looked across the board, we said, okay, we got to get a handle on that, and where will we go with that?
Thank you. One of the questions we often get, and it appears here, and we received this in advance of the meeting from all of you out there, and that is the question about how do you engage your leadership in the efforts that you described. I know PSOs are challenged by this. So, Vereline, can you tell us that? How do you engage your leadership?
Well, each one of our managers and directors participate in leadership rounding, and that's where they go throughout the facility. They usually pair up, and they go throughout the facility. They talk with staff, with visitors, with patients about their patient safety concerns or any type of safety concerns, but we do address patient safety concerns. And this is done on every shift and on the weekends. And any issues are forwarded to the appropriate person to address. Some are sent to the Patient Safety Committee for review. Some might be sent to a particular department or nursing practice. And so that's how we get them engaged. Each one of our leaders also have patient safety as a regular item on the agenda when they conduct their staff and department meetings, and they have metrics that they follow, and that's part of their performance improvement work. So they are very actively seeking and soliciting any type of issues that might affect patient safety.
Okay, thank you. And Chris, this one is perfect for you. How do you engage physicians? This is also a question that both PSOs and providers are often voicing.
Oh, it's never a problem. No, just kidding. So part of it is with data. Many physicians are very motivated by data. So getting the data that you submit to the PSO and then bringing that forward to your physician colleagues. And then we try to engage them on their more competitive level. You do good work, right? Oh, yeah, I do good work. Well, our data isn't quite so good. So what do you think we ought to do to get this data looking better? And kind of engage them on the competitive side of things. And that's been very, very effective. I think we're a little bit advantaged by being in the children's hospital in that when you start talking about harm, nobody that works at children's hospitals, physicians included, ever wants to think that anything they've done has ever harmed a kid. So when you start saying, okay, we need to really think about ways that we can reduce harm, they get very engaged.
Okay, great, thank you. And actually, maybe this is for both of you. How do you share your PSWP in ways with leaders and staff within the organization for analysis and for action planning purposes? We also, and maybe you want to follow this through, had a similar question, sort of how do you close the loop and disseminate what you get back from the PSO back to your organizations and staff?
Mm-hmm. Well, we actually do this in a variety of ways. When we have, if there's any type of a change or as a result of analysis of an event or looking at our data, our risk data and other patient safety data, our hospital-acquired conditions and so forth, if there are any changes in procedures or policies or as part of that action plan, we actually engage our staff to assist in developing the action plans, and then we communicate that through several ways to ensure that all of our staff are informed if there are any changes. I actually issue safety alerts periodically within our own organization. We do that through our periodic competency sessions, and we also report our data at our patient safety committee and various other improvement committees, and then that's disseminated throughout the organization. Our leaders actually post their patient safety data in the department so that the staff on a daily basis are seeing where they are as far as improving, CAUTI and CLABSI and falls and medication errors and things like that.
Yeah, so this is Chris. We do the very similar things to Vereline, but I don't know that for us it's as good as I'd like it. So if I were to walk up to an individual staff member, we have those same type of boards around with safety data up there, and the vast majority of the staff would say, yeah, I know about it, but how do they affect it is not always as robust as I'd like that. So one of the things we've been doing more on some of the units is a pilot, which is, we have a daily safety huddle where we have charge nurses and leaders come to the safety huddle. We do them on night shift. We do them on weekends as well as on day shift. And some of the individual units are doing it. And what we're doing now is doing an exchange of the information both back and forth, right? So that whoever comes to the huddle for the hospital from their own unit is expected to have talked on the unit about stuff to gather ideas, and then when they come to the huddle, if they've heard something, to take that back and then share it with staff. And that seems to be a lot more effective than we've had with the usual postings on boards, emails, etc.
That's interesting, Chris, because we have a couple of our units piloting the safety huddles, and we feel that we've had some great success. One of our units was focusing on safety with infusion pumps and use of the safety limits, and as a result of the huddle and just focusing on that safety aspect among others, that particular unit, which was our orthopedic unit, actually increased their compliance with using the safe limits by 23% in 1 month.
Wow. That's really great.
So we're really looking at the whole safety huddles, and then of course expanding that out. So I'm glad you mentioned that. Great.
Vereline, you actually just hit on one of the other questions we had received. What are the outcomes that you use to measure success of patient safety implementation, and how reliable are those measures? Chris, maybe you want to take this because I think Vereline just mentioned one way they do that.
Oh, well, that's a struggle for us, and I don't think anyone that I've talked to has that completely dialed in. I mean, you'd like to know what all the outcomes are, and sometimes it takes a while. For us, we score a lot of our events as what we call serious safety events, where we've had a deviation in practice. This is some of the HPI methodology, and it allows us to aggregate all of our safety events, not just in buckets of CLABSI, CAUTI, and then you begin to feel like you're playing whack-a-mole, and to say all of them and where did we have a deviation in what we would consider best practice, and did that result in some harm to the patient? And we'd like to see that rate go down, and we post that everywhere, as well as when we've done something like that, we actually share the story about what happened to the patient. And for some people, the data is very meaningful and changes things, but for a lot of people, stories mean a lot more than the data. So we do it both ways. And that way we're able to show, we have a nice little stick figure of kids that have been harmed with the various levels of harm. Some of the other children's hospitals have done it, but we found it to be very powerful, because then when you see an event, there's a picture of a kid there, right? And then each time for the month, there's like a little bar graph, and each kids pile up. And you don't want to see any kids on that month. And so a month without a kid there is a good month.
Thank you. Vereline, I wonder, have you had any changes in your event review process as a result of PSO participation?
We've actually been trying to improve our safety culture, and I think that's something that everybody's working on, just trying to move toward more open reporting, including self-reporting of events and being more transparent. And one way that we're doing that is incorporating the Just Culture algorithm into the follow-up with staff, so that the appropriate follow-up is done and that it will take fairly and based on their behavioral choices. And we've worked with our PSO in trying to establish and move toward that culture of safety, or just culture. And so we really are looking at that, and we actually include that in our review. When we review an event or a serious event, then we make sure that any deviation or any actions by the staff or any outcomes, that those are sent through that whole process and the appropriate thing takes place. And we had a very good event that occurred where we did have a staff person who was involved in an event. And we went through the process, went through the algorithm, and basically there was some coaching that needed to take place. It was a very new employee. It was a blood event. And as a result of that, he actually became one of the speakers for our nursing grand rounds where we reviewed that particular case with all of our nursing staff. So the staff saw that the process does work, that this person, it could have been a very serious situation that happened. He's still here. He's speaking out, and he's telling his story in an effort to help others be more cognizant and on heightened alert about those type of high alert type of activities. So it was very, very successful. We also look at contributing factors like handoff and IT issues and all of that when we do our review. So that has really helped, and that was because when we report our data, those are some of the things that we report to our PSO. So.
And then maybe both Vereline and Chris, what's the best way to capture all the different kinds of data that need to be submitted to the PSO? Do you have any comments about maybe processes you've changed for doing that, or methods that you've changed in order to provide the kind of data you need to for PSOs?
Well, this is go ahead, Chris.
Go ahead, Vereline.
Although we are actually manually submitting our data now, and we are in the process, I believe the best way to capture the different types of data and all of the supporting materials that are protected and all of that is to submit it electronically. And we have the ability to upload our RCA documents and other documents into our personal system, but we hope that this information will be able to be seamlessly transferred to the PSO when we get that process in place. And we are our decision support analysts are actually working with our PSO IT staff to establish that process. And so I think once we do that, I think that better information and more information will be sent, and that will really facilitate better analysis and feedback and all. So.
Yeah, we're very similar. We've been able to do it electronically through our patient safety reporting system that we do internally. So then it becomes relatively seamless then to submit to the PSO. But not all our stuff gets reported into the patient safety reporting system. Through the advent of safety huddles and some cultural work, we've been able to increase safety reporting about 2 to 3-fold over the last year or two. So although we're quite happy with that, it's still just the tip of the iceberg. And the big part of this is on the physician side, what happens at an M&M conference. So that stuff generally doesn't go into a patient safety report. That, in our institution, the vast majority of those are filled out by nurses. And so I've been going around to groups of physicians as they do their M&Ms to put in patient safety reports so that they can use it to categorize their events, right, and see what buckets they fall into so that they can look at them, but also then so that we can send this stuff off to the PSOs and learn that way.
Thank you both. And another for both of you, how do you continuously keep staff engaged in the safety culture and get them to report near misses?
Well, within our organization, our Good Catch program has really, really been beneficial. We get Good Catch reports from all sorts, different areas, different types of staff, from security to patient care areas, and that has really, really helped. And I think the fact that they are recognized and that they see that there are things that change as a result of them submitting those, it really helps. I think that developing that trust among the staff and feeling comfortable with reporting things is so crucial. Now, as a patient safety officer, the hospital staff see me all over the hospital. I'm always out making rounds, and one of my goals is to develop rapport with the staff so that they will be very comfortable with reporting, not only through our system, and they can report anonymously now, but really developing that rapport with them. And as a result of that, I've come across some very interesting type of patient safety issues that we were able to remedy as a result of that. So I really think just having the rapport, letting them know that it's okay to report these things, that having just culture there. So if I report on something that I did, or a mistake or a near miss or something, that if everything's going to be okay, they're going to take it to heart and make that change.
Very similar. We have at our safety huddles where we have people coming to make sure that they're continuing to report and bring up stuff. We try to make it as safe as an environment with leadership present, so that we do want to hear from things. Occasionally we get things like gifts. So we're close to Detroit, so the Detroit Tigers occasionally give some tickets for the games that won't be as well attended. We'll pass them out to people at Safety Huddle only if they bring up an issue. So no issues, no tickets. And that generates a lot more conversation on those days, because to say to people, we really do want to hear what you have to say. Disciplinary action won't happen to you if you make a mistake. We all are going to make mistakes. The question is, how do we handle it when we do it? And how are we going to keep from doing this again? Now, obviously, if you make the same mistake over and over again, that's a different issue. But that's so rare that it really doesn't happen that often.
Well, you may have both touched on this, but are you receiving any reports anonymously?
Yes, we do occasionally receive reports anonymously. We have a patient safety hotline, and staff can report any type of event, whether it's a medication error, anything like that. They can report on that line anonymously, and then we follow up on those things. And our reporting system, remote data entry system, has the ability for them to report anonymously. And we communicate that to staff also, so they are aware of that.
Yeah, we similarly have an anonymous reporting piece of it, but very, very few of them come back anonymously. And I like to refer to the people that self-report, which is by far and away the toughest report, as my hero.
So can you tell us what processes have been implemented that have really helped your hospitals, achieve a higher level of patient safety? Vereline, can you give us some idea?
Well, I think one of the biggest things that we've done recently are incorporated into how we address safety problems, because prioritization is just, it's so important. We have so many different initiatives and CMS programs and stuff. I think that implementing the CUSP program, Comprehensive Unit-Based Safety Program, has been so beneficial. The staff on their unit decide how the next patient is going to be harmed, and they work together to look at their processes and put things in place and prevent, the things like falls and things. I think that is one thing that has really changed the dynamic here at St. Francis. And like I said, our Good Catch program, having the ability to do anonymous reporting with risk data entry is important, and just encouraging staff to do that. Of course, we've implemented things like the WHO checklist, surgical checklist, and the central line bundles and things like that. But I think overall, CUSP has really, really helped us. We had one of our units, our inpatient rehab unit, that went 127 days without a fall through the work of their CUSP team, and they're continuing to be successful. So.
Yeah, for us at the Children's Hospital, I think the processes that we've done really involve engagement of the frontline staff. I think Vereline hit it on the head. So we recently went in our neonatal intensive care unit a full year without a CLABSI, and we were probably 2 or 3 years ago having one every month or two. And if you go back and look at why did that work, well, it was in large part because there were a couple of very engaged staff nurses. Yes, they had leadership support, yes. But that's where the work really comes from. And the question is, how do you find those people? How do you get those unit champions on board? And we had another process that we had, which is for medication dispensing out of the pharmacy. Most of those meds are drawn up by a pharmacy technician. Our pharmacy technicians, are not our highest paid employees, but yet those are the people that are drawing up each one of those medications, putting a label on it, sending it out to the unit. And how would we engage them? And so part of it is we had them, rather than just delivering the medications to an Omnicell or a Pyxis machine on the unit and viewing the nurses as the person who just comes to the window to yell at them, where's my medication? We actually have them deliver them to the bedside in the ICUs. The nurses love it, and they're now the medication manager, and they're walking around proactively saying, oh, I think your epinephrine infusion's getting low. I'll go get you another drip. Do you need anything else? And now the medications are appearing in the room before the nurses even had a chance to look in the EMR to see that I've written an order for it. The nurses love it. The pharmacy techs are engaged, and we've had a lot of good catches come from them. They're out delivering one, and they look at it, and they go, this doesn't seem right for this kid, because they see the kid. And they catch it and take it back.
Thank you both, Chris and Vereline. I can't thank you enough for today's presentation. Not only did you do a great job on the information that you shared, but I think you've answered many of the questions that we've received, although we still have many more that we can get back to you on, hopefully through other webinars. We'd like to remind you that, since we are at the end of our time, that if you're interested in receiving any email updates about the AHRQ PSO program, including announcements of future events like this, you can visit the AHRQ website and sign up for specific updates to the PSO program. So thank you all for participating in this webcast. An evaluation survey will be sent by email following the event. We appreciate your feedback, and when you've completed the survey, please remember to click the Submit button. Again, I want to thank the speakers for sharing their stories and thank all of you for attending today's event.
Thanks, Diane.